Okay, let's begin. Good afternoon, everyone. This is Peter Berman again, Director of the School of Population and Public Health at UBC, and with my co-chair for this, Tanya Bubala from SFU, for this BC COVID-19 Research and Collaboration Symposium, Public Health, Populations, Health Services, and Impact. Welcome you back to the afternoon events of the second day. We have spent a full day and a half almost entirely focused on British Columbia, with a few forays into other parts of Canada and an occasional mention of other parts of the world. And now we're going to really sharply switch gears and give the floor to many of our colleagues who are taking the research competencies and engagements of our institutions in British Columbia into exploring issues around COVID-19 in the rest of the world under the broad title of global health. There's hardly been a better example in my lifetime of a global health problem than this one, since almost every country and territory of the world has been affected in a very short period of time. So it certainly is global. And there are many, many important issues, and we'll get a bit of a flavor for that. So we've got 8 presentations and 90 minutes, 10 minutes each, and everyone will get gold stars for saving a minute or two as we go along. We'll try to offer a chance for 1 or 2 questions after each presentation, which can be put on the chat, or it's possible to raise hands. I would prefer if we use the chat if we can, because it's easier to just reduce the transaction time to connect and disconnect people and so on. Our first speaker today is Kelley Lee. Kelley, are you there?
I am here.
Okay, great. And I believe all the speakers have been given the chance to share screen if they are so inclined to do any kind of presentation. So go ahead, Kelley, over to you.
Okay, I am going to share my screen now. Hopefully you can all see that.
We can see it, great.
Excellent. Right, well, thank you, Peter and Tanya, for the opportunity to share our project with this great audience. I want to begin by acknowledging that I'm giving this presentation on the unceded and stolen traditional Coast Salish lands. And I also want to begin by saying that our take on global was very much including Canada and BC. BC is a very globalized province. Canada is a globalized country. So this is not about health out there somewhere. Largely in low and middle income countries, this is also about Canadian health. So with that, I want to present this project, which is about travel restrictions and cross-border measures, which is very much, I think, on people's minds at the moment regarding COVID-19. Here's our project team. We call ourselves the Pandemics and Borders Project. It's a lot easier to say than our CIHR title. We are collaborating with 4 universities and a number of knowledge users, and I won't go through them, but it's a great group, and we were thrown together very quickly, as a lot of groups are, and seem to be making good progress. The starting point for our project is the concept of governance, and governance to us means the rules and processes by which an organization or any society collectively steers itself towards an agreed goal. And we know that in previous public health emergencies, governance is incredibly important. If you have good governance, good global governance, you will have effective response. It's the basis by which collective action occurs. So when you have an outbreak, what you don't want, and what I think we're seeing, is individual action as opposed to collective action. So that's really our starting point for this project. At the global level, what we have is something called the International Health Regulations, which is an international treaty that is supposed to bring together countries to coordinate together in terms of responding to an event such as COVID-19. There are basic principles involved on how countries should behave and how WHO should act accordingly. And what we found is that there's real questions about how effective the IHR has been, whether countries have complied with it, and so on. So what our project's doing is really looking specifically at cross-border measures, looking at how what countries have adopted what measures, when, and how. We want to look at the evidence of how effective these measures are. We want to dig in and conduct some case studies of decision making at national level on why these measures were adopted. And finally, the real endpoint is to support better decision making, more effective decision making around the use of these sorts of measures. We're a quarter of the way through, so we still have very provisional findings. But what we've done is start to compile this massive data set, looking at every measure that's been adopted by every country. And it's a pretty tall order, but we're making good progress. We've started to analyze some of this data in terms of what measures have been adopted. And this is data between January and March of this year. So still there's quite a lot to go yet. But what you can see are the different types of measures that have been adopted, and there's a lot of different ones, and which ones are the most popular among countries. So very impressionistic denial of entry initially in the first few months was the most popular measure adopted. The other thing we're doing is looking at the timing. So this graph just really shows the red point where the public health emergency was declared and when the pandemic was declared. And perhaps not surprisingly, what you'll see is a lot of measures adopted after those 2 points in dates. But there's still a lot of measures being adopted along the way as we go along. So what are we learning from this so far? We're still analyzing, crunching the information that we're collecting. The first thing I think is that we need to extend our focus beyond just these at the border measures. A lot of people talk about slamming borders shut, closing borders, and so on. It's actually a much more complicated picture than that. What we have to look at are pre-border, at the border, and within the border measures that actually work together or in conflict with each other. And it's this whole basket of measures that we need to manage when we're thinking about borders, not just, for example, not allowing people in, restricting travel. We have to think about how we actually combine a number of these measures together or not. And so it's actually more effective to think about border management as a tap. So it's not about closing a door, but it's really about opening or closing a tap. And then what kind of, how much we open and close the tap, but then how we actually filter as we're using the tap. And all of this, just to say though, is that if a vaccine comes along, this is all going to be a very different picture. This is a situation where there is no vaccine at the moment. Okay, and then I guess the other thing we have to talk about in our project eventually is these lifting of all these different measures. So imposing them is one thing. How do we actually safely, relatively safely lift them once they're imposed? And lots of people are already trying to do this, talking about travel bubbles, corridors, bridges, and so on. Well, bubbles are popping all over the place. Corridors are collapsing. It really does point to the need for a coordinated approach. And as I said previously, it's about looking at the whole range of measures at different points of travel. It's about looking at different ports of entry, because we often just look at air travel, and when we need to look at land, air, and sea together. We have to look at source and destination countries and the relative risks posed for those countries, and so on. So there's lots and lots of coordination needed than we have at the moment. So I'm racing through this, but I just wanted to give you a flavor really of the kind of work that we're doing. We are slowly getting up to speed in terms of social media and a web presence. So hopefully we'll be able to give you more information as we go along. But that's it from me. Thanks.
Great. Thanks, Kelley. That was so super efficient. Very interesting project. You've earned at least one question. Is there any one question coming forward? I don't see any right now. Okay, well, we'll give the opportunity later. Hopefully there'll be some time up. Are you able to evaluate the extent to which measures are enforced, loopholes that undermine their absolute implementation?
Very good question. And that is one of the big issues, is that you can impose all sorts of things, but if you haven't followed it up with things like compliance, contact tracing and so on, it really is ineffective. So we are definitely looking at that.
Great. Thank you so much, Kelley. Really interesting project. Our next speaker is Heidi Tworek from the Department of History and the School of Public Policy and Global Affairs at UBC. Heidi.
Thanks so much, Peter, and thank you to you and to Tanya for putting all of this together. I'm very grateful to be here. I'm now just going to share my screen with all of you. Okay, so this is a project that seeks to understand the role of communications, particularly within democracies during COVID-19. I've put here a list of the people who are working on this, because we're also working in a whole host of original languages, as I will explain. But we also have collaborators, including Travis Solway, who's at SFU, and Eve Tabergian, who's a political scientist at UBC. So on April 23rd, many of you may have read this, Bill Gates wrote a very long note about how he thought that we were going to deal with COVID-19. Something that stood out to me as someone who works on communications in all its realms is that there was only one sentence Gates devoted to communications, and it was this: it will take a lot of good communications so that people understand what the risks are and feel comfortable going back to work or school. But this quotation obviously raises a whole host of questions. They include, why is communications only about going back, recovering from a pandemic? Why do people like Gates not see communications as integral to pandemic management from the very beginning? And what on earth did he mean by good communications? So some of the things that we seek to do in this project are to consider communications as a crucial non-pharmaceutical intervention, that communications in many forms can actually help to increase compliance, can help to, in the long run, improve people's mental health, and so on and so forth. But what we also see and think about in this project is, how does communications around the pandemic intersect with a whole host of other existing crises that we see in democracies? A lot of people have talked about this pandemic as an accelerator of, for example, inequality and so on and so forth, but it's also potentially, if we're not careful, an accelerator of many of the troubles that we see within democracy itself. Populism, the erosion of local journalism, and things that we've already been seeing like anti-vaxxer activism on social media. So what we're trying to do in this project is, by looking at how a whole host of countries and jurisdictions have responded to and communicated around COVID-19 as democracies, we're trying to think about, what does it mean to communicate democratically during a pandemic? Not just to communicate, not just as a top-down intervention, but what does it mean to do that within a democracy? So to do that, we've done a big comparative analysis. The entire team has looked at sources in the original languages from all of these places, places that tended to respond well in terms of communication, having things that were clear, consistent, compassionate, and that accorded to the 5 principles that we've developed to think around how you might do successful democratic health communications. So we looked at South Korea, Taiwan, Germany, New Zealand, Canada, Sweden, Denmark, Norway, and Senegal. We also wanted to look at a couple of provinces within Canada, obviously, British Columbia and Ontario. So you can see that there's a whole range of countries that we're looking at. They have very different healthcare systems. Some of them are more centralized. Some of them are quite federal. Some have reformed quite dramatically in terms of how they deal with communications since SARS and MERS, particularly Taiwan and South Korea. So we also, where appropriate, have compared with places that have done, we would say, a fairly poor job in communicating, including the United States and the United Kingdom. So what we did was, we had a standard questionnaire to look at how communications happened, who was doing the communication, how was it received, and so on and so forth, to pull out what we saw as some best practices from these different 11 jurisdictions. So this is really, in many ways, an intervention in trying to show communications as a crucial non-pharmaceutical intervention, but it also gives us insights into how these countries really governed during the pandemic. So what I'm going to do now is just give you a sense of the 5 broad principles that we've pulled out, that we then illustrate with a bunch of examples in a report that's coming out on September 15th. So one of the things that we know from other papers is that the rapidity of how we responded to the pandemic had quite strong effects on how well the pandemic was contained. And that also applied to communications guidelines as well. But one of the things that we found is it wasn't just the speed there were other principles behind the public health communications within these democracies that worked well. So these are the 5 rapid principles that we've developed and we'll put out in this report with lots of detailed examples. The first that we suggest is that at times it can be better to rely on autonomy, not orders. It doesn't mean that enforcement is unnecessary, but it does mean that autonomy and giving individuals within parameters or businesses within parameters the chance to exercise some control and communicating they have a certain amount of control can prove very beneficial. We've seen that within the way that Bonnie Henry has framed this, and we're now seeing some conflict in a way between how Bonnie Henry is framing this versus public safety officials like Mike Farnsworth, who want to bring in greater enforcement. But we found that some reliance on autonomy and communicating that can help individuals to feel more under control. And the second is our advice to attend to values, emotions, and stories, not just facts. We've seen that ranging from instituting gratitude as something that is talked about when you communicate with the population, acknowledging emotions, whether they are negative or positive, and providing specific individual stories that help people to see themselves in those who are being talked about. In Senegal, for example, they would post individual stories on official government Facebook pages. The third thing that we suggest is that you need to pull in citizens and civil society. So rather than seeing communications about health as something that's solely top down that comes from officials, that instead citizens and civil society are given a key role in framing how they want to communicate. To use another example from Senegal, one of the successful things they did was from the start to bring in religious leaders, particularly Muslim leaders, who would show themselves washing their hands and communicating in ways that made sense, so that these figures of authority helped to increase uptake of the various guidelines the government was pulling out. And the fourth thing that we found was that institutionalizing communications was also tremendously critical. In South Korea, after MERS, there was a massive reorganization of how their CDCs functioned. One of the things that was done was create an Office of Communications that then would specifically communicate around infectious diseases. And so the minute that COVID-19 came along, there was already an institution that knew what its job was and could move very, very swiftly. So it helps to give some weight to communications. It's going to go beyond the one sentence of Bill Gates if you have an office that is dedicated to this, to keeping up with the latest research and so on. And the fifth thing that we advise is to think about how you can describe the pandemic democratically. As I mentioned before, political scientists and others are deeply concerned about the state of democracy. If we are not careful in this pandemic, democracy will find itself even more under threat, as we've seen in various authoritarian leaning regimes that have used this pandemic as an excuse to crack down further on civil liberties, not just for a short period of time during the pandemic, but in a more long-term framework. So we suggest, for example, avoiding the use of military metaphors. We found in places like New Zealand, those metaphors were consistently and consciously avoided in favor of things that were pro-social, describing the community, and so on and so forth. So the approach that we're taking in this project is probably quite different from the other projects you've heard around COVID-19, which have mostly focused on the problem of what Tedros is calling the infodemic. So Dr. Tedros wasn't the first person to coin this term, but it's certainly become much more prevalent over the course of the last 6 months, as we have seen evidence of huge amounts of health misinformation, but also all sorts of disinformation around figures like Bill Gates, like you can see here, circulating around the internet. We have a huge amount of evidence now that this kind of infodemic does have real world consequences. So one study has found that nearly 800 people have died after following advice that they could find on social media, or advice, we might say. But what we're arguing here is that while it's incredibly important to try and deal with what we might call this negative information, there's also all sorts of constructive roles for public health officials, government officials, and citizens and civil society to put out reliable information, to communicate about science and about health in ways that diverse populations can understand. And we suggest these principles and give examples in our report about how you can actually go about doing that. So let me just wrap up with a few conclusions. One thing that we have found is the massive importance of learning from other democracies. We couldn't have put this report together without, for example, including places like Senegal, which have a tremendous amount to teach, British Columbia, Canadians, the United States, and so on and so forth. The second thing is that this is a deeply interdisciplinary project. I'm both a historian and I work in public policy, but this includes epidemiology, political science, communications, anthropology, and so on and so forth. And then finally, we found that you just can't think about communications as something that's top down. You come up with something, you go to a press conference and you throw it out there. There's so much more to it. We can think about it as the 6 C's: clear, consistent, compassionate, commensurate, constructive, and contextual communications that are alive to the context in which they are being put out, that includes citizens and a diverse civil society in how we talk about and think about this pandemic, in the hope that we can emerge with democracies strengthened and not democracies weakened. Thank you so much.
Great, Heidi. Thank you so much. One question that has popped up is, how about concerns about the politicization of communication?
Oh, it's a great question. So one of the things that we look at is what we call the division of labor as to who is actually communicating. And we find here that BC is actually an outlier, because in many other places, like for example, New Zealand, we see a division of labor where the Director General of Health will talk about scientific facts and the politician will talk about the meaning of the pandemic. The same is true in South Korea as well, where, for example, President Moon talked about how this can be a democracy strengthening exercise. For example, in South Korea, they actually had a vote during the pandemic and had quite a high turnout. And it was the political figures who gave democratic meaning, but the scientists who actually provided the scientific facts. So BC is an outlier in that Bonnie Henry is often doing both. So that can certainly be a choice, but the place where it tends to not work very well is when the politicians are doing everything. So that's certainly something we find to be very important.
Great, thank you, Heidi. Okay, let's turn to our next speaker, Susan Erikson, a professor at SFU. Susan, are you there with us?
Peter, I am here. Can you hear me okay?
What a nice view. Yes, we hear you fine.
But I seem to have disappeared myself, and I've been trying to find myself again, and I haven't been able to do that. So the options are I can proceed, or we can you can give me a little bit of time to figure it out, maybe come in again.
Okay, if you would prefer that, do you have a presentation that you've not been able to get to find?
Presentation, can you see that?
Yeah, it's working. Why don't you go ahead?
Let's just go ahead with that then.
Yep.
So I'm a medical anthropologist, a professor of global health at SFU in the Faculty of Health Sciences, and I've been following political economies of global health for several years now, with a particular focus on the financialization of global health. And I've just finished up a course, so this is more than you need to pay attention to. I want to bring your attention to some of the changes in global financing, global health financing, and health financing more generally speaking. If we think of Plan A as that turn towards the nation state provisioning and management of healthcare, and we see attempts to actually bring about systems that will provide healthcare for most of the people most of the time. What we've now moved to, and there's a lot in here which obviously I won't be talking about, what we've now moved to though, where I will focus, is on this tension between the push towards universal health coverage, but it's both an and a versus, the increasing financialization of global health. And I pay particular attention to what's called innovative financing. So I'll just give 2 examples here very briefly. There is so much to talk about this. These are very complex systems, but let me just give you a quick overview of the kinds of things that I'm tracking and teaching and actually doing research on. So in the first case study, this is just an example of the way that hedge funds and private money have made their ways into public health, and the kinds of things, the way that business metrics have really taken up more and more space in terms of organizing particular interests in global health. So if we look at a US biotech company called Vaxart, it has recently gotten some attention because it became the focus of US Operation Warp Speed. That is a US policy intended to put a lot of money to accelerate vaccine production. So this biotech company, which has never brought a vaccine to the public before, it only has about 15 employees. It has, its largest shareholder is a hedge fund, Armistice Capital. And before the pandemic, Armistice Capital bought up about 2/3 of Vaxart's shares. And the founder of Armitage Capital actually joined Vaxart's board. Now, a lot of these things aren't legislated, the special interests aren't tracked, and even when there's a whistleblower alert about some of these things, there's always the question of enforcement. So the founder ended up buying shares at about 30 cents a share. So January, before the pandemic really takes hold, we see Vaxart, because a lot of vaccine producing companies, actually their share prices increased. By April, it increased quite a bit. And by June, it had increased from 30 cents a share in 2019 to about $14 a share. What this meant for Armitage Capital is that June, 3 days after this $14 share price hit, Armitage Capital actually ended up just selling the vast majority of its shares and made $197 million without the vaccine being produced. So my point here is to just really send out a kind of alert to public health folks that the kind of good and well-intentioned initiatives that people assume that public health efforts and public health monies, that we might need to interrogate that and look at that a little bit more critically. I'll turn now to a second case study, and that is work that I've been working on since 2016, and that is looking at the way that insurance is being used to actually create what they're calling pandemic bonds. And I've wrote about this in a much longer article in Medicine, Anthropology, and Theory, an article called Global Health Futures, Reckoning with a Pandemic Bond. And the details of this are, again, quite complex. I won't go into it, but just know that this is a pool that the World Bank has put together, a $450 million pot in anticipation of a pandemic coming. And perhaps the idea was that the bond would last for 3 years, that investors would put up their money. And if there was no pandemic during that 3-year period, then the investors would make a fair bit of money. Now, what we saw with coronavirus is, in fact, there were many instances of Ebola where people thought that the pandemic bond would in fact trigger. It did not trigger for the cases of Ebola in the Congo, but we did see that with coronavirus, which is one of the viruses that's covered by the bond, it did in fact trigger after 2,500 people died. And so this is, again, just to give you another quick example of how it is that people are making money on the pandemic. There's a lot of details here, but if you want to get a sense of how much money people could potentially make, there were several pandemic bond investors who invested $50 million in this bond. And then what that meant was that at the end of the 3-year period, the $50 million investment would actually end up resulting in a $7.4 million return. Lots of details here that I don't have time to get into, but just want to introduce this idea to you. There was some payout in the case of the coronavirus. The payout actually came out, this was issued in April, but the payout was to IDA countries, and the minimum was $1 million, the maximum was $15 million that you could apply for, and $195 million of the $450 million pool was in fact ultimately distributed. So something a bit different there for your attention, but just wanted to give you a sense, perhaps maybe I did nothing more than just broaden the kinds of things that global health researchers in BC are looking at.
That's great. Thank you very much, Susan. Also time for a question if there is one. I will just make a little plug that we're hoping to invite for a seminar this fall, the person at the World Bank who's been running this pandemic bond enterprise, who does tell me that the investors have actually lost quite a bit of money now because of it. So anyway, any other questions for Susan? Okay, let's move on. We're right on time. Perfect. Our next speaker is Mike Law, a professor at SPPH at UBC. Mike, can you, Susan, could you unshare your screen? And Mike, you can take over.
Yeah, can you see that, Peter?
Got it.
Perfect. So hi, everyone. Thanks very much, Peter and Tanya, for the invitation to join you today and to present some of the work that I'm doing with colleagues to respond to COVID-19 in a number of countries. So essentially today I'm going to take you on a quick tour of a CHR-funded project that I'm engaged with colleagues from 7 countries and including American collaborators as well. So just to give you a brief introduction, so routine health data, for those of you who aren't familiar with the term, is data that's collected in the sort of everyday function of the health system. So in a lot of countries, we've over the past decade, we've seen really rapid increase in the number of electronic data sets that have become available and are being assembled in countries across the globe. And the picture here is of very non-electronic records, but what you see in a lot of countries is these formerly paper records being turned into digital records. These can come from a number of places. So researchers in Canada will be used to the insurance billing data sets that provinces will use. In a lot of countries, DHS2 based systems are often used. So this is a software package that a number of countries use, and it's the District Health Information System. And so these will be facility level statistics on health system utilization and health presentation. So whether number of deliveries or things like that. The advantages of using routine data are many, but they're longitudinal, rapid, and low cost. And we can get into a discussion of their disadvantages if you like. Just to give you a sense, we've used these before in research that I've been part of as part of my team. This is a chart from a project that we did in the Democratic Republic of the Congo during the first Ebola virus disease outbreak and the current outbreak. So this is in 2018. And you can see what the DRC did is they introduced a free care policy in the middle of 2018. So that's the second dotted line. And you can see in the red and blue areas, which are the areas that had that free care policy put into place, the total visit rate in those regions to health facilities went up quite dramatically as a result. So there was some concern that people wouldn't present to health facilities, but this free care policy seems to have done a very good job of eliminating that. So that's one example of a project. So in this case, we went to CHR with 2 questions about the use of routine data in response to COVID-19. And so the 2 research questions that we went in with were first with syndromic surveillance. So in each of the 7 countries, we were going to look at what local and regional areas are showing signs of patients showing up with COVID-19 associated symptoms, and whether we could use those as indicators that would precede testing in a lot of areas, particularly if testing is constrained. And then the second question that we were looking at is using these same data to look at health systems utilization. So in the 7 countries we're working in, did we see changes in the use of both COVID-related and non-COVID related health services as a result? Because you wouldn't want to see, say, drops in immunization or facility delivery as a result, because people would fear going to these health centers. In terms of our team, we've got 7 countries. So Haiti, Mexico, Lesotho, Rwanda, Liberia, Sierra Leone, and Malawi are all part of this through links with the Partners in Health associated sites in each of those countries. So my co-PI, Bethany Het-Gauthier at Harvard Medical School, and I have been working together in Rwanda since the early 2010s, and we've managed to include co-PIs from all of these 7 countries in collecting and using this data. So what we're collecting in those countries is a little bit different in each country, but largely similar across the board. So you'll see here that in one country, Haiti, we're using a surveillance system that is based on weekly data collected from health facilities. But the majority of these countries, Lesotho, Liberia, Malawi, and Sierra Leone, and as well Rwanda, are all based on DHS2. So these are statistics that are collected at the facilities every month by someone who's dedicated to collecting them, and then sent to a central database. Rwanda says HMIS, but that's their technical name for their DHS2 system. And then in Mexico, we're using EMR data from the facilities that Partners in Health serves in that country. And you'll see here the data availability is one of the most amazing features of using routine data. Essentially, by the middle of every month, we can get last month's statistics. So in comparison to collecting things in a fashion like through a survey or something of that sort, these are incredibly fast and incredibly up to date. And then what we're doing is collecting the data from all of those sites. So you'll see on the left side here, we have the sites sending all of these count data aggregated by facility and date, essentially by the middle of each month. We have a data processing pipeline set up where those data are collected, cleaned, and we do statistical modeling and produce data visualizations via graphs and maps in 2 to 3 days. And then we have monthly calls with all of the sites to discuss what we're finding and what we're seeing as we proceed. And to give you a sense for some of the data, we're right into this now in terms of the syndromic surveillance, and we're starting to pull data out on the health services utilization part of things. But just to give you an example, here's some of the facilities in Lesotho that we're tracking as part of this project. And you'll see here that when the pandemic hits in early 2020, you start to see pretty precipitous drops in the monthly counts of outpatients. So the light purple line is what we predict we would have seen based on previous year's utilization, and then the black is what we actually see. And you can see that things drop off fairly quickly when the pandemic hits. So as we develop this project and continue to assemble the data, we're going to do more of these types of analyses where we use time series methods to predict what we would have seen had things not changed due to the pandemic. And as well, we'll engage in more formal interrupted time series analyses like the one I showed you earlier from the DRC. So then finally, in terms of the deliverables, just to give everyone a sense for what the outcomes of our project are. We're producing monthly reports for sites. So these will go to the Partners in Health facilities in each of those countries, as well as to national level decision makers like ministries of health. We're going to produce a website with code in order to provide the basis for others to do this sort of syndromic surveillance and assessment of changes in health services utilization. So everything is being coded in open source platforms like R. So we hope that others will be able to utilize that website use the code to do these things on their own end. We're going to have a training course put together by the folks at HMS that is going to go through essentially doing a syndromic surveillance exercise with country's own data. And we're hoping for more traditional academic publications out of this, some of which will be methods oriented in nature, and others will be the impact of the outbreak on various, the use of various types of healthcare services. So that's all I have prepared for today. Happy to take any questions, and thanks very much.
Great, Mike. Thank you very much. And also very efficient presentation. I'll look for questions, but let me start with one. This is a very interesting area of work, of course, and there have been some both provocative and as well as disturbing papers written about the potential impact of drop-off of other kinds of care, perhaps much greater health impact than COVID itself. What is your group thinking about how to use this information for remedial measures? What are people thinking about? What can be done about this?
It's a great question. So I think, a lot of that will be specific to the context in which it takes place. So, for example, the work on the free care policy that we did in the DRC suggested that co-payments were a big factor in dissuading people from seeking services in that country. So, in that case, the policy change of giving people free access was an obvious way to try and alleviate that. So in a lot of these places, it's going to be specific to the context, and we're not at the point yet where we've seen these things and been able to assess what what policies or interventions we've seen in various countries that might be related to that.
Okay, great.
I wish I had a better answer for you.
Thank you. Well, we'll come back to talk about this when we hear from Annalee and Jerry about health worker safety, because one of the interesting aspects of that is making health workers safe may also make people perceive health facilities as being safe as well. So interesting. Anyway, thank you very much. We're right on time. And our next speaker is me. So I am going to share my screen. And I hope you can all see my slide now. And I'd like to share some information about a research program that a group of us at UBC are engaged on to look at the role of politics, organization, and governance in the governmental response to COVID-19. We use this acronym IOGP, Institutional, Organizational, Governance, and Political Factors. And broadly, we come with these kinds of definitions. Institutional refers to the higher level formal and informal rules of the game. This is kind of bringing an institutional economics approach to this. Organizational is more about the organizational and structural and functional design of the public health and also the other health system and related elements in national or jurisdictional areas. Governance, we're focusing more on how the parts of this design relate to each other and what are the processes through things do or do not get done. So rather than the more common approach of creating an index of good or better or worse governance, it's more about a process analysis. And for the political category, we're interested very much in how politicians and the political processes support or constrain effective public action. Now, why and how do IOGP factors matter? I think one interesting example of this is that in 2019, a global health security index was created. Before the pandemic, it scored 195 countries around the world on pandemic preparedness. The US and the UK ranked #1 and #2. And the index overall does pretty poorly in predicting effective response to COVID-19. Why is that? Does IOGP explain some of this discrepancy? They looked at an objective set of measures on preparedness, and we find that it doesn't really predict the actual response very well. The hypotheses are that IOGP is a key determinant of how knowledge is produced and used to guide government action, and how well directions for action are implemented by organizations and also responded to by citizens. So it affects both the supply side, what is accepted as known and by whom, and this links to Heidi's work on communications, and what is done with the knowledge, and also the demand side, the trust and confidence of citizens in government direction and their compliance. And it affects three important areas of government action, which we've been discussing the last 2 days: the public health response, that is the response more specifically focused on the prevention and mitigation of the spread of disease, the clinical preparedness and treatment response, what do you do with the population who become ill and severely ill, and also the non-health actions. And we've seen these three domains are all impacted on by the way IOGP factors take place in different jurisdictions. Here's a simple graphic which just tells you a little bit of why this might be an interesting story. At the top, the disease progression in Canada, in the middle, British Columbia, and on the bottom, Ontario. The gray bars essentially represent the period when almost all the non-pharmaceutical intervention measures were put in place in Canada. And you can see, comparing British Columbia and Ontario, very different patterns of the development of the epidemic curve. Raises the question, why these differences? Some of it might be environmental and contextual factors, but is some of this difference due to these IOGP factors? So some things that mattered in British Columbia, we've talked about the strong legislative powers in Canada for the provincial health officer, strongest in Canada, according to a recent analysis. A highly capable provincial health officer, political leadership that deferred to science and expert knowledge, and the relative lack of disruption by opposition politicians, which we haven't seen so much in some other jurisdictions, a single payer medical care system, which allowed rapid action to be taken, and a high degree of social solidarity in the population, and early action and time to mobilize these in the early stages of the epidemic. This is a logic model for our research, and I just want to point out that we are recognizing that there are important contextual factors, but the politics and institutions, the organizational actors, and the governance, and then moving down more towards intervention, the effectiveness of intervention, the timing of intervention, and ultimately the outcomes. The red items down here highlight the fact that we really do lack data on the organizational design of the health system response, as well as on the governance processes. And this is the area that we're trying to focus on in terms of the research that we're developing. Our research plan right now is we have a multidisciplinary research team at UBC, largely linking together researchers at the School of Public Population and Public Health and the School of Public Policy and Global Affairs. We're developing measures and instruments for these IOGP factors, and particularly for the organizational and governance factors, because there are quite a number of political and institutional indicators and variables that are measured on a regular basis for many jurisdictions. We're developing an early application of this approach through an in-depth British Columbia case study. We're planning for an online symposium with global collaborators to review and strengthen these methods. In other words, to share our efforts at methods development and get feedback from global colleagues as to their relevance and usefulness in their own contexts. We hope to develop a series of country case studies, again, focusing on these IOGP measures, relying primarily on secondary data and media, and then bringing together the widely available data on interventions and outcomes that are being reported quite regularly for almost all countries around the world and many subnational jurisdictions. We'll be opportunistic about this in selecting countries, but also hope to do some more purposeful selection of countries for these case studies. And we've been developing collaborative research with in-country partners, initially with Peru, India, China, and Ethiopia, but also exploring other opportunities. The impact of this work, I think it's important to note that this is probably work that's most useful not for the next 3 months or 6 months, but probably for the future responses to public health crises like COVID-19, because IOGP factors don't change very rapidly. So this is really about developing the organizational models, the legislative and regulatory models, and documenting better practices that leaders could try to adopt in the future. And so this would include better legal and regulatory frameworks, advocating for more and better investments in human resource capacities and other inputs for the public health response, replicating better organizational models for public health functions, learning from experience on how to mobilize non-government capacities in line with public policies, and initial design of better capacities, especially in many emerging economies where they are, in fact, in the process of developing these capacities going forward. So that's from me, and I will stop my slideshow and see if there are any questions in the minute I left myself. Tanya has a comment. Let's see, I have to go down to my questions. Okay, I don't see any specific questions, and I'm not going to ask myself any questions. So let's go, let's see if I can find my agenda again. End of slideshow, click to exit. Did I exit my slideshow? Can someone tell me?
Yes, you did.
I did, okay. Thanks, that's really multitasking. Okay, our next speakers are Annalee Yassi and Jerry Spiegel from SPPH at UBC. So turning it over to you. I see I did get a question at the end, but I'll Annalee Jerry, are you there?
We didn't unmute. Okay, sorry. Do you have our screen on? Is our screen on?
Not yet, not yet.
Oh, let me see how we could. 1 second. How about
There,
now?
got it now.
Okay.
Okay, great. And we'll be doing this together as we do many things. And we'd like to begin just by sending huge thanks and appreciation to the organizers of the symposium and this session for what a wonderful start to the new academic year, and as well to have this get together on such an important area of focus. Now, we talked a lot about context in your presentation, Peter, and we'd like to really focus on the context of working environments and do this in resource challenged settings, as Mike was speaking in terms of approaches in those kinds of settings. And this is in South Africa, that's part of a study that's looking at contextualized global occupational health in Canada and South Africa. We were recently funded by IDRC through the CIHR Rapid Response Competition, but this really continues a collaboration we've had going since 2006 through the network of WHO collaborating centers. And it shows the importance of developing strong partnerships to extend this kind of work. Through this work, some of which we'll describe, we have extended for this competition to 2 health authorities, the Vancouver Coastal Health in Canada, but notably the Gauteng Department of Health, which is the largest province in South Africa. The reason why the South Africans were interested in developing this partnership and invited us in was because of their particular needs that they saw. If you look at TB incidents in the country, you see a rate of 100 times greater. And in 2006, it was even higher. We see with COVID-19, we see that the situation for active cases in South Africa has been worsening. And although the death rates are similar, if you see the active cases are really growing at a huge rate, creating tremendous burdens on their health system, which is already strained. And in Gauteng province, which is our main partner for the case study we'll describe, there's 79,000 total healthcare workers. There's been 45 deaths and over 5,000 positive healthcare worker COVID cases in this year.
So the rationale for our study is that healthcare workers worldwide are at increased risk of occupational infectious diseases. We've known that for a long time, not only from TB, but SARS and Ebola and flu and everything else. But different jurisdictions take different approaches with respect to the PPE recommendations, contact tracing, testing, return to work policies. And policymakers want to know what works best to protect healthcare workers, in what context, using what mechanisms to achieve what outcomes. In other words, this fits very well into the project that Peter just talked about, because looking at what are these organizational and system factors that influence the infection of healthcare workers, especially in low and middle income countries. In addition to the infectious disease hazards that face healthcare workers, from airborne and droplet spread and contact spread, that there's a myriad of other workplace factors that interact with it. That unlike the situation in Canada, for example, where we have lifting devices, people that in other countries that's why long-term care is such a hotbed of care, because they're very, very close associations. People work long hours. There's violence from angry patients. There's mental health concerns, including stigma and the concern from healthcare workers taking illness home, as well as various other occupational health issues. So over this last 15 years, we've been working with our colleagues to train people in audit tools and improving knowledge hazards. We've used all sorts of various study designs, including a cluster randomized controlled trial in 28 hospitals. So this is a very mature partnership that have gone into many different areas, but also very closely working with the WHO and the International Labour Organization and using their tools. We've developed training programs in the past to build local capacity to participate in these kind of projects. And it's, obviously really key for us to constantly keep in mind the history and socioeconomic and political context, because the legacy of apartheid, as well as economic globalization, is just very clear in every aspect of what we see on the ground. And we need to be cognizant of course, the complexities. Every organization has its own organizational culture and its own quirks, and the complexities of respecting local knowledge and in each setting. We've had the advantage, because we've been working in a multi-scalar way with international, national, provincial, and facility level collaboration all the way along. So the particular project that we've gotten funded for is multi-component. It involves in-depth case studies using interviews, document reviews, putting together the qualitative analysis to really understand the health system aspects of all of this. We also have another sub-study that's focusing specifically on the mental health of health workers. And we've embedded this in, since we're very active, both our South African colleagues and ourselves, in our WHO network of what's going on comparatively across 161 countries. The centerpiece, though, is a case control study to look at why healthcare workers get sick. Is it occupational? Is it community? Is it the transportation? Is it lack of PPE, lack of awareness, and so on? So back to Jerry.
So in taking at this study, and we're doing this work in South Africa, along with some other work in Vancouver coastal area, but we wanted to look at very much at the contextual factors, as you had addressed, Peter, but as also Annalee was explaining. What are the conditions that enable better policies once we look at the mechanisms and their impact? So we're trying to have, through the case studies, a good appreciation of what exactly is transpiring, answering perhaps that challenge of having a better organizational documentation so that we could link it to other determinants or factors that are associated. And we want to be looking at specific policies and interventions that we identify to see what their effect has been in relation to these outcomes, especially through the case control study, but also through the more qualitative case study. And look at that in the context of what are the drivers. Now, one of the aspects that we wanted to look at, specifically building on previous work, is the way we're actually using the information that could be generated routinely as we manage this. And if we're really learning as quickly as we can to such a challenge. And the basis for our original partnership was the application of an information system called OASIS. And that's something that our colleagues in South Africa have developed a specific module and code that's capable of producing timely dashboards and reports for the National Health Laboratory Service throughout the country. Now, as I said, this was the original source of the interest that they had to have the adaptation for this information system, which they now actually have the code transferred to them. So they actually manage the system. But it raises the question of systems like this is, do they, especially in such a politicized environment as occupational health, do they function as tools, as weapons by some of the parties who use parts of the information for their own use? Or are they white elephants, as many information systems are? So we're revisiting that 15 years of history in a crisis situation to get a better appreciation of what's a success factor.
So the challenges in this particular research project is, first of all, the fact that the pandemic is rapidly evolving, but also because most of us who are involved in this also have service responsibilities, and it's tough balancing the research elements and the pressures of health services at the same time. The digital divide is still very real internally within the country that hurts a lot of the the mechanisms of what happens within the research. There's research fatigue as there's lots of research going on, and data sharing issues. And unfortunately in South Africa, governance and corruption are still very, very much concerns. This was something from just yesterday where the MEC, the equivalent of the minister, was fired for rerouting a huge amount of money that was supposed to go for PPE. So these things are there. But the mitigating measures that we're using, which we were asked to specifically look at, is the research is very much anchored in the service. It's needed for informing the day-to-day activities. So there's engagement in it, because right by the knowledge users are the people involved. We're involving a lot of students as research staff, which will help remove the burden from the key investigators, and trying to collaborate and as much as possible with other studies so we can facilitate data sharing. So to end, I think a lot of you have seen the slide many times before, that if you're coming to help me, you're wasting your time. If you're coming because your liberation is bound up with mine, let's work together. As Peter started with at the very beginning, there's probably no better example of a time where the health needs anywhere are a health need for all of us. So the incentive to work together is extremely strong. So here's just a list of the various collaborators. On the Canada side, we have Vancouver Coastal Health, as well as UBC. And in South Africa, we have University of Cape Town, University of Wits, and the National Institute for Occupational Safety and Health, as well as the Department of Health itself. Thanks.
Great, thank you, Annalee. We could take a question if one is forthcoming. We will have time at the end, the way this is going, for some questions and discussion. Nothing is jumping up on my screen, so I will then make sure we have time at the end. Let's move on. Our last two presentations are going to shift gears somewhat to look more at specific groups of beneficiaries and specific types of outcomes. Julia Smith from SFU is our next presenter. Julia?
Hello.
There you are. Great.
Great. Let me just share my screen. Here we go. All right. I'm going to talk about the Gender and COVID project today. And we are implementing this project. I'm working with quite a large international team here. The project's based at SFU and funded initially by CHR, and then more recently expanded through a grant from the Bill and Melinda Gates Foundation. And we're conducting research in 9 different countries. You can see Canada, Brazil, Nigeria, DRC, Kenya, Bangladesh, China, and Hong Kong. And we're looking at the gendered effects of the response to COVID-19. So this is somewhat different in the sense that we're not looking necessarily at the effects of the virus, but the effects of the response. So the different public health, economic, and social policies that have been implemented and how those have affected people of different genders differently, and either exacerbated or addressed inequities. In doing this, there's a high component of policy analysis, looking for gaps and opportunities to advance gender equity and gender transformation. And we also aim to provide some very concrete guidance and tools to policymakers and decision makers in these countries, as well as globally. So I realize many of this might not be completely new to many of you, but in terms of the rationale for the project, I think it's important to reflect on why a gender-based analysis is necessary when we look at outbreak responses. And many of us know that health crises have very differential impacts on male and female bodies, so on people, and we can see that with lots of different types of health crises. And initially with COVID, we were seeing, very different rates of infection and outcomes on males and females. And that's starting to change and become a bit more confused. And I think that does relate to the fact that health crises are also structured by social and economic and political differences. And that's what this project is really about, is how men and women and non-binary people are affected differently by crises response. Many of us in the project have written about this extensively, specifically as concerns women, and recently published a commentary in Nature kind of outlining this past research. It takes examples from Ebola and Zika that show, for example, with the Ebola outbreak in West Africa, women were not only most negatively affected in terms of their economic opportunities during that outbreak, it took them longer to recover from the outbreak economically. So we have that evidence from the past. We also have evidence that crises response can exacerbate inequities. And the worst example of this, again, comes from the Ebola outbreak in West Africa, where resources were diverted from maternal and reproductive health services to the outbreak response without consideration of what that would mean. And consequently, maternal mortality and the rate went up 70% to the point that more women died giving birth than from Ebola during those years. So, there's a strong need to take these sort of issues into account. We recognize that much of this past research has focused on women specifically, and there's a need for a much more complex understanding of the gendered effects and also how gender interacts with other identity factors. And the COVID, outbreak is having very specific social and economic impacts on people of different genders and, again, different identities. And that's something that we're trying to understand and document in order to inform more equitable responses. As I mentioned, we're working across a lot of different geographies, and each team in that geography is implementing the project in slightly different ways that reflect that context, understanding of gender in those contexts. However, we have developed this grounding framework, which is a COVID and gender matrix. And this is a simplified version because the full version has way too many words for a PowerPoint slide. But it's sort of our grounding framework for how we start our analysis, the types of questions we're asking. It reflects the interdisciplinary nature of our team. So our team includes health system scholars, it includes anthropologists, it includes political scientists, economists. And so we're really looking across a range of gendered factors, so access to resources, how gender norms impact people's experience of the response, as well as types of effects or impacts. So everything from health impacts, such as infection, to economic and security impacts. This tool is evolving and continuing to grow. It's also being adopted by other research teams, which is quite exciting to us. So we know people in other parts of the world that are also now using this, and it's being translated into French, Spanish, and Portuguese to facilitate that sort of, widespread analysis. In terms of methods, we have a mixed methods approach. In some countries, we're focusing primarily on the qualitative interviews, so qualitative research. So here in BC, I've done about 25 interviews to date, and I'm doing key informant interviews. Around the world, we also are doing a lot of administrative data analysis, and we're doing surveys, quite extensive mobile phone surveys in 3 countries. It's one of the challenges, and quite honestly say we're experiencing is wanting to do a very intentional mixed method approach where the qualitative and the quantitative and the different aspects interact and inform each other, but at the same time, trying to respond to a rapidly changing situation and demands for evidence and data now. So that's something we're grappling with. Despite working across very different geographies and contexts, we are already starting to identify some global themes in our initial, very, very initial research outputs. So, the crisis in the care economy, the need for childcare, the impacts of school closure, and how that's, particularly impacting women is something we're seeing in each case, and we're looking at it in more detail in terms of how that interacts with women's health and well-being, as well as economic opportunities. We also recently co-authored a report with UN Women that kind of tries to sketch out some of these themes in terms of impacts on the Sustainable Development Goals. So this is kind of the, where our outputs we hope will both be very specific national and local contexts, as well as some global level analysis to understand how this crisis is not just a health crisis, but it's affecting gender equity on a global scale in some very concrete ways. One of the key partnerships of our project is the Gender and COVID Working Group that was kind of grew out of this project from the very beginning. This is a working group that now includes over 400 members around the world, and it's everyone from health professionals to national and global policymakers to academics. We meet once a month and have these epic Zoom calls with multiple, dozens and dozens of people and have a number of other resources happening. We've hosted forums. We have a Mendeley library. If anyone's interested, I highly encourage you to join. Just yesterday, through our gender working group, we were able to present to Dr. Tworek at the WHO, and he is now committed to including a gender working group within the WHO's response. So we're quite excited about that, to see some, early activity in the policy sphere around incorporating gender-based analysis into the response. And I'll leave it there. Thank you very much.
Great, Julia. Thank you so much. And again, I'm not seeing any hands or questions coming up so far. So I think we will move on to our final speaker, Professor Laura Ackman from Department of Psychology at SFU. Lara?
Oh, hi, thank you. I'm just trying to share my screen here.
Okay.
There we go.
It's come up, and
Perfect.
please go ahead.
Thank you. So hi, everyone. Thank you for the organizers for putting together this event and so quickly. My name is Lara Ackman, and I'm an associate professor of psychology at Simon Fraser University. My research focuses on the antecedents and consequences of human happiness and well-being, with a particular focus on if, when, why, and how helping others through kind or otherwise helpful behavior can promote our own well-being. So today I'd like to share with you some statistics on how Canadians have been reporting their mental health over the past few months under COVID. And then in light of these data, I'd like to present some results of our recent experimental work investigating whether small acts of prosociality can offer a short-term boost to mental health during the pandemic. So as you might imagine, the past few months have had a negative impact on Canadians' mental health and well-being. Results from a large crowdsourced survey of over 46,000 people conducted in the early months of the pandemic showed a threefold increase in the percentage of Canadians indicating that their mental health is fair or poor compared to 2 years prior. Now, it's worth noting that these data are not probability-based and therefore should be interpreted with some caution. However, they are consistent with recent results from the Canadians from Stats Canada's probabilistic web survey, which suggests that over 50% of Canadians say that their mental health has decreased during the pandemic. Now, these summary statistics mask some important details. In particular, 88% of respondents report at least one anxiety symptom over the past 2 weeks, and 41% of people indicate symptoms that are consistent with moderate to severe levels of anxiety. And importantly, these rates are even higher in some subpopulations. For instance, 64% of youth between the ages of 15 to 24 report symptoms of moderate to severe anxiety. And these findings are not limited to Canada. For instance, earlier this month, the CDC in the United States reported a stark increase in symptoms of anxiety, depression, and suicide ideation, and again, showing gross inequalities of how this is represented across the population, and particularly high rates in vulnerable groups. So with more people experiencing adversity and experts warning that vaccines and pharmaceutical solutions may not be available for some time, researchers have been underscoring the importance of developing novel interventions to protect mental health and well-being. To this end, my colleagues and I have examined the efficacy of one potential strategy, which is helping other people. Why helping behavior? Well, a large and interdisciplinary body of research suggests that people are exceptionally generous creatures. People give of themselves in various ways, including donating their time, their money, their blood, their food, and advice to other people. And while some theories and theorists might assume that humans could retract and withdraw these pro-social efforts in the face of adversity or distress, numerous accounts actually suggest that human generosity persists and can sometimes even increase in emergency situations. For instance, data collected in Louisiana in the 3 weeks following Hurricane Katrina documented impromptu emergency support of pro-social behavior from diverse groups like hotel workers, hospitals, and various communities in response to the catastrophe. Moreover, humans not only engage in a wide range of generous action, but they appear to derive emotional benefits from doing so. Over the past decade or so, my colleagues and I have found that helping others through simple, small acts with as little as spending $5 on another person as opposed to oneself, for instance, can lead to measurable benefits for one's own well-being. Our initial findings were documented here in Canada and in the United States, but we've since conducted surveys and collected data from responses from rich and poor countries around the world, including responses from over 236,000 people sampled through the Gallup World Poll. We've also probed this relationship in toddlers just under the age of 2, and most recently in large pre-registered experiments with a total sample of upwards of 7,000 respondents. In short, we find a robust evidence for the short-term emotional rewards of generosity. And so we questioned whether this finding might persist and be of use during the pandemic. Now, this hypothesis extends clearly from the literature I just described, documenting the emotional benefits of pro-social behavior. However, it did seem plausible that these typical findings might disappear or even reverse in the face of the COVID-19 pandemic, because some have argued that this is the largest collective trauma that most living humans have ever experienced. It seems possible that COVID-19's imminent threat, exceptional spread, and an ever-increasing death toll could significantly change how people empathize with others. And so my colleagues and I conducted 2 large pre-registered experiments to see whether generous behavior, captured here in a form of generous spending money on others as opposed to oneself, can improve mental health again during the pandemic. So as I mentioned, we conducted 2 large pre-registered studies. In both cases, participants were recruited for a short study online. The study methods are presented pictorially here, so I'll pull out the main events. The survey began by asking people to report the impact of COVID in their daily lives. It assessed their intrusive thoughts on COVID-19 and asked people to report their baseline levels of affect or emotion. Afterwards, people were randomly assigned to either a personal condition or a pro-social spending condition, in which they received a small sum of money that they could use to purchase an item either for themselves or a needy other. Now, specifically in study 1, participants in the pro-social condition could choose between making a donation to one of 2 real charities, and participants in the personal spending condition, could claim a $1 worth of cash, an equivalent value, for themselves either via Google Pay or Apple Pay. In study 2, we adopted a similarly conceptual design, but here we tried to manipulate whether the items purchased were COVID related or not. So specifically, participants in the personal spending condition could buy either a mask or hand sanitizer for themselves, or in the non-COVID specific condition, either an edible treat or a writing tool like a pen for themselves. Meanwhile, in the pro-social spending condition, people could choose between buying these items in the COVID-specific condition. They could pick between sanitizer and a mask for someone in need, or in the non-COVID condition, a granola bar or a pen for someone in need. Now, after making these spending decisions, people were asked to report their current emotional well-being, complete another COVID thought intrusion task, and complete measures about fear and worry, and finally some individual different scales. So consistent with the overwhelming majority of our pre-registered predictions, we found that participants randomly assigned to make these small acts of generosity for others with as little as $1 worth reported greater well-being on various indices of mental health and well-being than people who spent the equivalent amount on themselves. Now, these data were quite consistent across studies and emerged regardless of whether the kind act was relevant to the pandemic by giving hygiene supplies or not. These findings suggest that one way to improve short-term mental health is to help others. This strategy stands to provide one low-cost, familiar, and accessible means for boosting well-being during COVID and beyond. In follow-up work, we'd like to examine how receiving these kind acts might help make the recipients feel. So among friends and family, these small gestures could help to facilitate feelings of connection while people practice physical distancing. And because kind acts can be directed towards strangers in one's community, these acts could potentially build new relationships. More broadly, I think these findings reflect the human importance and their capacity for care, and they show that even in some of our most challenging times, helping others can also help ourselves. So thank you. Oops, sorry for that final point popping up there. So thanks for your time. Excuse me, here's a link to the preprint and my email and contact information in case anybody would like to be in touch.
Great, Lara. Thank you so much. A nice note for our final presentation on generosity. I think we can also say that the very great participation we've had in this event has been a good example of that also. Any specific questions? There is a question for Lara. Can you please show slide 2 again, the
Sure.
results of the survey?
Yes, just give me 1 second to reshare my screen and backtrack the results of here you go.
Okay.
If helpful, I can put the link to the survey findings and write up in the chat box.
That would be great, I think. Okay. So I've got 2 questions that have been posed in the past and previously that we could come back to briefly, but I'd like to leave at least a couple of minutes for open questions and comments. One question for Jerry and Annalee. Does your health worker analysis, what does your health worker analysis say about gendered, contextual, and organizational factors, from Julia Smith? In other words, are there gender differences in these contextual and organizational factors in what you've been doing?
Yes, I started answering that in the chat. The vast majority of healthcare workers are female. There's very strong elements for a very strong basis to do gender analysis. Also in South Africa, domestic violence has been very much on the rise. Plus there's bullying in the workplace that's come up as being a really big concern, which is gendered as well. So there's many dimensions of it. To be honest, we haven't structured a real project to look at it. We had good vocabulary on it and to get our grant and a nice little blurb. But if there's someone who wants to join our team to specifically look at the gender-based analysis, there's certainly room for that, and we'd very much welcome that.
That's great. Thanks, Annalee.
Yeah, I have a question, by the way, for Laura, if there isn't a long
Go ahead.
questions which is one of the things that we've been sort of playing around with, is this whole issue of volunteers versus paying people. In the little sort of service work that I'm doing in Vancouver Coastal, we've had a huge number of people volunteer to help. So we accommodated about 20 volunteers and that were working great, and everything was structured wonderfully. But then at a certain point, I began to feel that these people need to make money. These are young people, and felt that it would be better to have fewer of them and pay them, so at least people could be paid for all their wonderful work that's being done in this pandemic. And so the flip side of doing acts of kindness is the potential of taking away other people's jobs and doing that. In other words, these folks should get paid to be doing some of these services especially at a time when jobs are so scarce. So I'd like to know, your thinking on that.
Yeah, so most of that's a really interesting question. I thought you were going in one direction, but it actually ended up somewhere else. That's I thought I had an answer prepared in it. A lot of the kind acts that we study in my lab tend to be these relatively small, mundane acts. They would rarely take away someone's profession or intrude on that boundary. People are buying coffee for someone in need, and most of the time, I think these are small, everyday, random acts of kindness, and that's what I typically study. And that's kind of a pragmatic result of the fact that we get grant funding that doesn't allow people to make huge donations and sums. That being said, I think if people, I think the emotional benefits of giving might certainly disappear to the extent that people feel like they're harming others. I didn't have a chance to cover this here, but we, in our work, a lot. I was a grad student at UBC, and a lot of it was done there in the early days. My work with Elizabeth Dunn there and others has found that there are key contexts that kind of increase the emotional rewards of giving and dampen it. one being this perceived positive impact, or this feeling like you've had a positive impact on another person. And so I can imagine that if you zoom back or increase the scope and realize that your kind deed is in fact stepping on someone's toes or taking away another person's job, that may very well likely hinder the emotional rewards, or in fact even reverse this effect.
Thanks.
Okay, thanks, Lara. So a question that was posed to me that I missed earlier came back again. And another question is related. So I'll try to take these two at the same time and open it up for others as well. So the question initially to me was, what would I speculate were the main reasons why the UK and the US were wrongly ranked so highly in the 2019 Global Security Index? And can I describe any general factors in the ranking that predicted poorly? I would say that the ranking, they weren't necessarily wrongly ranked. They were ranked based on a very elaborate process of identifying more objective indicators of preparedness, which had to do with organizations and capacities and so on. And they probably were ranked correctly in the sense that they were highly prepared by those objective measures. What I think is interesting is that being highly prepared by those objective measures did not have a high predictive value for the actual response in different countries. And some of the countries that responded very well, Vietnam is a very good example, was ranked number 50 in the index. So I think that, and this is now coming into hypotheses around the work that we're doing, but I think one simple statement is that poorly performing politicians can undo much objective preparation, would be one explanation I would have. And that there are things that we might learn about legal and regulatory structures and remedies that could be put in place to potentially reduce the impact of politicians on these functions, and also the role that citizens might have in accountability and so on in doing that. So the related question for others as well, do any of the international studies focus on the influence of the political situation that are focusing on the influence of the political situation also consider curbs to irresponsibility or frank abuse, like an effective judiciary or accountability mechanisms through free press or citizen initiatives, and what those could accomplish? So I think those would certainly be in the areas of hypotheses that we would consider in our work, but maybe I'll open that up to any of the other presenters if they'd like to comment on that.
Right.
Yeah.
Come right in.
Yeah.
Okay. We're just wondering if you're looking at factors such as Gini coefficients, perhaps as a proxy, a suggested proxy, because in terms of interpreting some of the findings of the global survey we've initiated some analysis that's trying to see any associations with Gini coefficients.
Yeah, yeah, and in fact, our preliminary analysis are showing that the more disparity there is in the country, the less healthcare workers are taken care of well, which makes good sense actually politically. So that kind of relates to the question that you were asking.
Yeah. Anyone else want to come in on that one?
Yeah, I was going to come in on that very briefly and just say, I think there are a couple of things. One is that if we look at race-based analysis, we can see that particular populations in the US and the UK are disproportionately affected. That also relates to healthcare workers, where we've seen that BAME healthcare workers have died at a disproportional rate, especially compared to the general population. And I guess the other thing that I would say is if you dive below the national, you can see quite strong differentiations, right? So Scotland versus England, Washington State versus New York State, right? Because we see that Washington State, they followed the CDC playbook as far as they were allowed to by the Trump administration. And when they did that, they had a much more effective outcome than, say, New York State. So I think there's actually much more differentiation when we dive down a little bit. And maybe the final thing I'll say as someone who's been participating in a long-running sort of international group thinking about rankings is, rankings measure only a tiny subset of things. And so one thing that we have to consider is, what did this ranking not go into? There were many factors that it didn't consider, a lot of the sort of softer stuff, right? If you want stuff that you can rank, you look for things you can put into numbers, and that can often be tremendously misleading. And maybe just very briefly, there was a question for me about the
Right.
universal versus the cultural specific. So one of the things we're arguing is that these are principles that need to be applied contextually, right? So who your civil society is very different in Senegal, where it's much more politics and religion and much more intertwined than, say, in a place like South Korea, where actually one of the major outbreaks has come from the secrecy of some religious leaders. But I do really want to push back against the idea that there's some sort of innate cultural reason why you have greater obedience towards healthcare measures. South Korea was a place where a couple of years ago, people were on the street every weekend demonstrating against their president, who was then removed. And now this current president has really quite high approval ratings. What we see in terms of compliance in South Korea is as much a product of how badly they performed during MERS as it is anything else. So I think we have to be extremely wary of any sort of attribution to broad sort of vague cultural attributes. I think there are much more institutional and historical explanations than that.
Okay, thanks, Heidi. That's a great note for us to end on. I agree that we'll have to have another symposium on cultural versus social and political factors determining social responses. So I want to thank our presenters. It's been a really stimulating session. Everybody was super good about keeping to time, and we really got a sense of the breadth of questions and issues that our community is addressing with more of a global perspective on COVID-19. And on that note, I'm going to turn the chair over to Tanya Bubala. I hope she's there, Tanya, for the synthesis session, and a good chance to also think about synthesis both locally and globally. So thank you.